this pooled analysis of PACE and OPTIC trials that's going to be presented at ASH. What it articulated was that Ponatinib, as a third-generation pan inhibitory molecule, has 2 trials that actually have a large portion of patients that have failed the second-generation TKI. It's actually the largest group of patients that currently exist after second-generation TKI treatment. And this collection of data then was articulated to show the Ponatinib's benefit-risk portfolio using these 2 trials. And what was shown was that using a response-based dosing regimen, the Ponatinib's treatment in a post-second generation setting in a resistant population was maintained while minimizing the safety impact that the drug may have with regards to arterio-occlusive events. So in a frontline setting, this really doesn't impact practitioners that much, right? It's really that resistant patient that actually is progressing to disease and their outcomes are poor. What the study showed was that when you, the PACE study was initially developed to get the approval for the drug accumulation, showed robust responses in this resistant patient population, where they really didn't have many options. And the response rates were really poor. It really showed really robust response rates. Now, what OPTIC showed, which was a response-based dosing regimen study, the studies have 2 that you can still maintain the responses while minimizing the safety impact that you can get from the trial. For example, PACE dosing regimen where you start the drug accumulation at 45 milligram, and there was no clear dose reduction strategy that was employed. Whereas in OPTIC actually employed a dose reduction strategy that actually was response-based. So once you reach a response called BCR-ABL 1%, you dose reduce to the lowest dose, 15 milligram. And what that did was that actually maintained that efficacy because you're starting at that high dose and achieving those responses. And actually, upon dose reduction, you actually, minimize that potential toxicity that you see with arterio-occlusive events. In fact, there was a 64% reduction in the toxicity that was observed with arterio-occlusive events, with showing about around a 5% rate of AOEs in the trial, really much less than what was observed before. One of the challenges that we've seen is that because of this fear of the drug's safety, it hasn't been leveraged in a resistant population as when they really got no other options, for example, for TP15I patients and patients who are highly resistant. These patients don't have a lot of time because the disease is so aggressive, right? So what was seen was that even in that setting, because of this fear of the toxicity, the drug was not being utilized. But what we're seeing now is that with the revised dosing regimen, that fear of the toxicity may be appeased because you can now manage the toxicity with the aggressive dosing regimen, dose reduction regimen that's been